Finals SAQ23 Inadvertent Intra Arterial Drug Injection. A. What factors predispose to inadvertent intra-arterial drug injection that could lead to severe extremity injury? This includes patient factors, staff factors, and drug factors. Patient factors. Patient being unconscious, thus unable to indicate pain on cannulation or injection. Hypotension or hypoxia. Failure to recognize cannula as intra-arterial. Anatomically anomalous artery accidentally cannulated, such as in the antecubital fossa, aberrant ulnar artery, at the wrist, superficial branch of radial artery, and thoracic outlet syndrome with loss of radial pulse on abduction or rotation of the arm. Staff factors include poor training, failure to differentiate between artery and vein, for example, inadvertent injection into brachial artery, failure to check which line is being accessed, failure to label line as arterial. Drug factors. Some drugs have greater potential for harm than others, such as vasoactive and hyperosmolar drugs. B. Outline the possible intravascular mechanisms of injury. This includes arterial spasm, chemical arteritis, initiation of release of harmful endogenous substances, such as thromboxane, which cause endothelial damage and activation of platelets leading to thrombosis, drug precipitation and crystal formation in distal microcirculation, leading to ischemia and thrombosis, and emboli formation, which forms from ATP released from red blood cells and platelet aggregates. This causes ischemia, gangrene of distal tissues. Arterial spasm may be due to the drug itself or release of vasoconstrictors such as noradrenaline. Chemical arteritis is due to direct tissue damage from the drug, causing endothelial damage and thrombosis. C. What are the acute clinical features of inadvertent intra-arterial drug injection? These includes intense burning pain at and distal to the injection site. The drug injection should be stopped immediately if this occurs. Pallor, blisters, failure of drug to have intended effect, edema, hyperesthesia, motor weakness, signs of arterial thrombosis, such as pallor, cyanosis and coolness of limb, and subsequently gangrene. D. What is the early management of an acute intra-arterial drug injection? Injury. First, stop the injection. Airway breathing and circulation assessment, to include IV access and administration of drug by intended route if urgent. Keep the arterial cannula in the artery. Consider iloprost or local anesthetic for intraarterial administration, but ensure no other use. Dilute the irritant. Flush the vessel with isotonic saline or heparin saline. Analgesia. Elevation of extremity to improve venous and lymphatic drainage. Vasodilators such as IV papaverine 40 mg or IV lidocaine 1% 5 ml to reduce vasospasm and provide analgesia. Consider anticoagulation with heparin. Consider sympathectomy such as stellate ganglion block, brachial plexus block, and guanethidine block for upper limb and lower limb blocks. Guanethidine is an alpha blocker that depletes noradrenaline stores. The dose is IV guanethidine 10 to 20 mg plus heparin 500 units in 25 to 40 ml of saline distal to the arterial tourniquet, which is left inflated for 20 minutes. The effects can last for several weeks. Documentation, explanation and apology to the patient and patient's family, followed up in writing, incident report, plastic surgery referral, and removal of the intra-arterial cannula once immediate reaction subsides. Remove cannula if hand is well perfused. Compress the site of cannula removal to avoid hematoma formation.